Good afternoon, everyone. Welcome to Grand Rounds. Today, it is my pleasure to introduce Dr. Dennis Boyle. Dr. Boyle is an internist and rheumatologist. He is Assistant Dean of Community-Based Medical Education and Associate Professor in the medicine of rheumatology at the Denver Health Medical Center. He also is a physician risk manager for COPIC, and we're quite pleased that he has been able to accept our invitation today to review patient communication tips. And please join me in welcoming Dr. Dennis Boyle.
Thank you for the introduction. My name is Dennis Boyle, and I actually visited your wonderful institution back in February 2020. And it seems like quite a long time ago, as I'm sure it seems for you. And lots happened in the meantime. I'm sorry this isn't live, which is really the preferable way, I think, to talk about communication. The communication actually is usually two-way, right? And in the format we're in, the Teams format, this is a webinar sort of set up, so it's mostly me talking at you. Be that as it may, this is an important area. The reason I'm interested in this is I ran the communication program for the medical school, University of Colorado. And I did that for about a decade. So I've been teaching and learning this particular area for years. I didn't really know much about it and sort of dove into it years ago and have learned a lot. And we'll share some of these thoughts on this. So here's the overview. We're going to talk about 6 different sort of points. The first is communication in general, which is important and learnable. We're going to talk about the introduction a little bit. Hit the idea of open questions, talk briefly about body language and summaries, and then sort of how do you end with a readback. And so I'll go in some very specific areas here. So let's have some fun, get going on it. So the first question is, how important is communication? Think on your own here. And so, the first thing is it is important. And there's a dilemma in what we do. We do have this idea as docs or nurse practitioners or PAs, and we have to find it and fix it. And I think that's important. I worked for the malpractice company, and yes, if you send home an MI, that's not good. So we really do want you to find it and fix it. So that's important. But on the other hand of it is this whole idea of patient satisfaction and patient connection. And there's a lot of really subtleties there, and it certainly is at least half of the issue, the thing we're doing with our patients. As you all know, eventually we all get to leave the planet. So we're not, for a lot of times, especially in adult medicine, which is what I'm in, we don't cure things. We just sort of treat them. And in the end, it's our relationship with the patients that's so important. So we're going to be spending time on how you might improve that. Your goal today is to say, what's the one thing here that he said that I'm really going to try today, make my interactions a little better? We get to do 100,000 interviews in the course of our medical career. And because of that, we all get really great at it, right? So each one of you, everyone is a great communicator. No, okay, maybe that's not right. So we get to do something over and over again. And because you do something over and over again, you really get to do it great. No. Over and over again does not mean better. And of course, that's the Malcolm Gladwell book where he talks about this. It comes from a fellow by the name of Anders Ericsson, who talked about the 10,000 hours. And what Anders really talked about the most was the specific idea that you really need coaching, you need feedback in terms of what you're doing to gain skill. So if you went to a desert island with a golf club, you wouldn't end up being Tiger Woods. You need to get even Tiger has a coach, right? So all of us need coaching. You need to be thinking about this. And sometimes the coaching can be your own coaching of doing so, but really an awareness of how you're how you're interacting with people, how things go. The next thing is communication is really a technique, and this is something that can be learned. When I started doing this, I didn't really know much about doctor-patient communication. I grew up in a time when we didn't really have much on it in the med school, and then I ended up teaching it. And I found that there really is, this is a technique, a teachable skill, and it really can be learned. So the important point of this is, there's this dichotomy. You got to find it and fix it. We're not saying you don't want to do that, but we want to say you do want to be able to connect with your patients. And you can get better at this if you try. And hopefully, that's what we're going to be spending the next 45 minutes on. Medical interviews are different. So that's one of the things. So there is really sort of 2 points on the axis. And there's actually a third point. And if I was better at PowerPoint, I could probably put that point on. The third point is time. But we have this idea that we actually get into really high emotion content discussions frequently. So if you're at the grocery store, most of the discussions aren't high emotion, right? So, but in medicine, you can literally be an ER doc, work into the emergency room, and say, your pregnancy test is positive. Congratulations, or I'm sorry, whatever the situation may be. You can get into some very high emotion situations. I think of my daughter with this. She's not a teenager anymore, but I think back to the days of my daughter, and most of the discussions I had with my teenage daughter were a lot of emotion and not much content. Those of you with teenagers can just chime right in on that. You understand. And then there's this access of gathering information, and we really do need to do that. In 5 minutes, you get to walk into the room. You need to be getting an idea of what's going on. And I think of air traffic controllers as the sort of the ultimate, people that convey information and don't use any emotion. So one hand, there's my daughter, high emotion, no information. Air traffic control, the opposite. But as docs or as providers, we're here. So you get 15 minutes, 20 minutes. You get high emotion some of the time, not all the time, but not everyone. Some people are in for hypertension follow-up, right? But there's certainly, there can be very high emotion. There can be bad illnesses. There can be life and death kind of stuff. And then there can be gathering information, which we really do need to do, to figure out what's going on, to be part of the find it and fix it thing. So medical interviews are really unique. And most professions don't have both of these really at the same time. So this is why, studying and learning about it is important. So then we get into the question of, why does good communication matter? So take a second, just think about it, and I'll run through sort of the reasons that I can come up with. So first of all, there's the whole HCAHPS thing. At the place that I work at, Nonverbal, we get our green box score. And the score that they actually look at the most is, my doctor really listened to me, or my provider really listened to me. And I think that's important. In Denver Health, you got to get 80% on that to get the green box. That's the big thing that they look at. But this patient satisfaction and stuff is important. And what's happening and what will happen more is Medicare is really paying based on this. So that's really the only stick that CMS has, and they will tend more and more to be paying is based on patient satisfaction. Now, right now, that's sort of at the hospital level, so they're paying the hospital more or less based on your patient sat scores, but it's going to trickle down to us, probably sooner rather than later. So good communication is important because the patient needs to feel that we listened. The second thing is litigation. I have a little more complex size on this, but effective communication reduces lawsuit. This is an ancient, article, but it still rings true. That in depositions, there's a lot of problematic relationships. People who sue usually feel deserted or devalued, and there's a poor information transfer. So lawsuits are high. And if we really look at lawsuits, really up to half of them really are based on really poor communication. Literally 10% of lawsuits, there's not a lot of damages. It's like, well, what are you saying? I'm suing because I'm mad at the person. And we see this all the time. We actually see situations where a person, we saw a case the other day at COPIC where a person lost their vision with temporaritis, and they had seen the family doc on either side of the emergency room situation. So three visits, family doc, emergency room, family doc. Patient lost their vision, unfortunately, with temporaritis that went undiagnosed. and the patient sued, and she sued the emergency room doc, did not sue the family doc. And in the deposition, she was asked, and she said, "Well, I love my family doc. He's great. The ER doc didn't listen to me." So, literally, like, right off the pages of yes, in effective communication really does make a difference. So you get a better story, and I think that's an important part of all this. You're much more likely to get the idea of what's going on when you do an open-ended communication. And we'll talk more about how long people have to talk, but you really are able to craft, with the good techniques we'll be talking about, you'll be able to craft a better story, get a better HBI, and know better what's going on. And as you know, and I think if you've been practicing for a while, you know that a lot of times with the more basic stuff of your profession, whatever world you're in, you actually learn very quickly what someone has by getting that story. When I'm seeing a new patient with fibromyalgia, I think my partners and I all say the same thing, which is you probably know in 10 minutes whether they, in 1 minute whether they have fibromyalgia or not. You just can tell by the way the story is being told and that first chief complaint. So you get a much better story when you're listening, connecting better. Adherence. There's a great Kaiser study where they looked at patient adherence, and they removed all the barriers. So the patients on the 3rd floor seeing Dr. Jones, there is no copays, Kaiser. They renewed the lisinopril. They sent the script down to the 1st floor. The patient walks by the 1st floor. They say, "Are you Dennis?" "Yes." "Here's your medicine. Do you have any questions?" "No." And no copay. So they literally, it's one-stop shopping, no copay, takes you 1 minute. And how many people pick their medicine up? And the answer is, I think it was like 62%. So really 40% of people, even in a no barrier situation. So if you're connected with someone, they're much more likely to pick up, the antibiotic or the lisinopril, whatever treatment that you're giving them. So. And then finally, in the world of burnout, and the most recent burnout statistics are frightening. The national burnout probably was in the world of 40 to 50% pre-COVID, but it's gone through the roof with COVID. It's in the 70 to 80% range. That's another talk, but there's no question that connecting with the patient, talking to your favorite patients, really does improve your satisfaction and knock down that patient, that personal dissatisfaction that we're getting. It could certainly be hard. So these are a lot of reasons why communication matters. It helps with the patient satisfaction, keeps you from getting sued. It helps with your own burnout, and it really helps you get a better story. You take better care of the patient. So that's the first. That's the first point. First point is communication is important, and you can do better with it. All right. So let's start with the introduction. And the introduction has actually changed recently, right? So not quite the same as it used to be. We'll talk a little bit about masks and COVID and things like that more at the end. So, but this is the first question: is how long does it take someone to decide that they like you? It's an interesting question. This is a doc seeing a patient, and think in yourself and sort of give yourself your own answer on it. And the answer is, it's probably 10 to 20 seconds or something like that. So it takes about 10 seconds for someone to decide they like you. So what are the components to a good introduction? And why do you think a good introduction is important? Well, so and then again, think about it. What is it about 10 seconds? Literally that means when you're walking in the room. So if you're walking into the room and you're over washing your hands, which you should do, and then you turn the computer on and you don't say hello to the patient and you sit in and check in and type in, the patient's deciding whether they like you or not. I guess they're, looking at, whether they know you or not or what you're doing. So one of the important things is that you really do need to be thinking about how you do your introduction, and how you do your introduction has now changed. So that's another, point. So, there's certainly no more handshakes. But the components are really here. So the first thing is, I think, I guess the last point, which is, hey, hello, how are you doing? Now, you do need to know the patient's name, and you want to do the to identifier kind of thing. I think that's important. But I do those, I'll sit down and I, and you, Mrs. Jones, or can I call you Sally or whatever, making sure you know what to call the patient. And, first of all, just say hello. It's okay to do that. Now, this is great. And if you're an ER doc and I come in tomorrow with substernal chest pain, okay, we understand that you may want to fast track this a little bit, but most of the stuff we're doing, you can sit down and you can really say the patient's name, how are you doing? And really sitting down, using some eye contact, smiling. And I guess now we're doing an elbow bump or a nod, and think about how you're doing that. The handshake is a fascinating deal, which is it probably came from the time of the caveman. And what it meant was, as I was reaching out to you, it was meant that my hand was open. I didn't have a weapon. I think handshakes have gone away for now, and I don't know. I have not actually had a cold in the last 18 months, so maybe they've gone away for good. There's something to be said for it. But think about how you're actually doing your introduction, and I think importantly thinking about it in terms of that 10 or 20 seconds. When you walk into the room, and I worked with a guy who was the master. He was always the best doc rheumatologist in Denver. He was my mentor, this guy by the name of Walt. But he would literally walk into the room and, to paraphrase Renee Zellweger, he would have them at a low. So he would walk in, good eye contact, looking at the patient. Mrs. Jones, how are you doing? You look great. And it works. So practice that. Interestingly, I gave this talk, so I sort of said to my wife, well, honey, let me practice with you. I'm just going to, practice my introduction with you, if that's okay. And she said, sure. And so I did my introduction. She said, it's okay, but, you didn't really look at me when you said hello. And, I'd like it if you look at me. So make sure you're thinking about this, actually maybe even practicing it with a friend or a significant other. Thinking about how, when you go back into the office this afternoon, how you're introducing yourself to the first patient. What do you do? Make it conscious. Be aware of that early 10 seconds to 60 seconds. In trauma, we talk about the golden hour. I think in communication, we talk about the golden minute. Nail it in that first minute. Be there, be present, and really connect with your patient right away. Make sure you're doing that. So that's the first part the second part. The first part's communication is important. The second part is think about your introduction, try to do a good job. So, this stuff is all about the patient and the person. And there's really, I actually like to do this early in the interview. I think at the time I was treating someone in the walk-in clinic setting, and they had a foot lac, and I was about halfway through their foot lac, and I was rapping with them, and they told me that they were a doc in one of the community health centers that I worked at, and it was like, and I didn't know, I hadn't connected their name and face, and it's like, really, I didn't know that this was a physician. I was halfway through sewing up their lac. I actually do this early. You got to get a social history anyway. Social determinant of health is, really important now on how we do our histories. So I find, I actually even start with, before we get, if I don't know you, I say, Mrs. Jones, before we get going, tell me a little bit about yourself. People will not talk forever. Everyone always thinks they're going to go on. I've never had a person, talk for more. I'm a banker, and I just changed to the new West Bank out on Broadway. They often just they tell you just a little bit to frame. It helps you build rapport, helps you build the connection, and it says I'm interested in you as a person. So I really do start my things that way. And this is that famous AIDET stuff, AIDET. If you guys had that at your institution, it went around about 5 years ago, making sure you're just letting people know who you are, what you're doing. So, and this is different in different situations. If you're in the emergency room situation, telling people, who you are, what you're doing, making sure they know you're the doc. A lot of people come in scrubs. It's hard to know who's who. In the office setting, I'm Dr. Boyle, and people are coming to see Dr. Boyle. So then most of the time they know that I'm the doc, and but making sure that they know who you are and what you're going to do today. as you get going, sort of setting the agenda a little bit too. So, and what I always start with is, so you're here, most of the time the people I'm a rheumatologist, half the people I'm seeing is rheumatoid arthritis. So you're here for rheumatoid arthritis. Tell me about having rheumatoid arthritis. So you need to ask the open question. Tell me what's going on with it. And it's, what's the difference between an open question and a closed? So the open question is, tell me what's going on. Tell me why you're here today. The closed question is, how's that etanercept been working for your arthritis? So the open question lets people sort of tell their stories. And there's sort of a lot of ways to do this, but the biggest thing is an open question. And the question to you is, how long does a patient have to tell you the story before you cut them off? Anybody know? Anybody? It's actually 18 seconds. Thought it was the next slide. It's not. That's actually a fairly famous study that was done at Wayne State now 40 years ago. That study's been done over and over again. It's actually been done 5 different times that I could find. And in all these studies, what they do is they sort of, with permission, tape the beginning of the interview. And the question is how long does a patient have before I take over? And what's interesting is if you just start with an open question and say, tell me what's going on, and then tell me more about that, to sort of get an open thing, and then sort of funneling it, which is what we do, patients will not go on forever. I mean, one study that was interesting is, I think if you ask docs, and I've done this a million times in an interactive forum, how long will people talk? I think the average you get is about 5 minutes. So I'll tell you that this is the only way I do my interviews. I always start with an open question. Tell me about what's going on. How are you doing? Tell me what's happening. Why are you here today? And I've never, in 1,000 interviews, the last 1,000 interviews, I've had like one person talk for more than 1 minute. They really never talk for 5 minutes. It's just so rare. There was actually a study where they looked at like 5,000 interviews, and there were like 3 people that went on for more than 2 minutes. They really have some remarkable data on it. So what we're suggesting here is an open question. And this allows the patient to sort of tell their story. And then we get into what then what I actually do is, and I have a frame for it, is I always say, so we've talked about the rheumatoid, so here's my doctor questions, and they know exactly what that means. So I'm going to ask you about the etanercept now. So here's my doctor questions, how are you taking it, and how often are you taking it, and do you notice that it works right away, or does it take a couple of days? Are you having any side effect, so you're getting into all that stuff. So that open-ended questions, and then the funnel, and the patient feels comfortable with this, and they're then allowed to sort of, then are allowed to, they know they can tell their story. So the difference is, as opposed to me coming in and say, how's the etanercept working for your arthritis? Then we've sort of definitely focused it down. And that brings us to the next thing, which is what's the average number of complaints that a patient has? And certainly the family docs know this. And what's interesting is there's actually a great study on this. It's 2.7. So we are framed a little bit with this. So I'm a rheumatologist. I'm taking care of rheumatoid arthritis in a patient. So because of that, when they come in for their rheumatoid arthritis, that's all we're going to talk about, right? Right? And even if you're an ER doc, and you say, and someone comes in for their foot pain, do you think that's the only thing they're going to ask you about? No, they always ask about something else. So the average number of complaints someone has is 3. And, our medical assistants, who are all dear to us, lovely, but they frame us because the chief complaint is the follow-up for the rheumatoid arthritis. So you're going in expecting that that's what they're there for. But the average person has 2 or 3 things they want to talk about. So the way you do this is you set the agenda and you say, anything else before we dive into the rheumatoid arthritis today? You really have to ask. And this is what we call setting the agenda. When you get the, oh, by the way, complaint, you didn't set the agenda. So And everyone knows what the by the way complaint's an interesting deal. I actually taught communications in Spain, and amazingly, people in Spain everyone speaks English. So I'm teaching communication stuff, and we were talking about this, and actually the person in the audience said this is the Pacienta complaint, because the Pacienta tribe always says one more thing, one more thing. Everyone in Spain that I was talking to knew exactly what this was. So not only do we know about the oh by the way thing, they do too. When you're getting the oh by the way complaint, that means you didn't set the agenda right. Everyone has 3 complaints. Basically, it's the rare person that just wants their hypertension meds and that's it. So ask it up front so you can, you don't want the thing where you get to the doorknob and, I'm there for the rheumatoid and the patient says they have chest pain. Well, I'm an internist. I can't just say, talk to your doc on that. So, so this really happens. Maybe less so in the ER setting, although quite honestly, most ER docs will tell me the same thing, that it helps to ask if there's anything else. So in building the story, what we're talking about is this 18-second thing that we usually start with closed-ended questions. So what I think is we should go more with open questions. This helps us understand the meaning. So open questions and then funnel. And remember that there is this, beside the 3 complaints, there's a chief complaint and there's a chief concern. So the chief concern, I've known about that since I started medical school, right? That was the first year I learned about the chief complaint, but there's a chief concern. So the chief concern can be different than the chief complaint. So the chief complaint can be cough. The chief concern is, can I get my, can I get the Zithromax, right? The chief complaint is fever, and the chief concern could be, I'm worried about COVID, or I want to get ivermectin. We don't want to talk about that today, but so you're building the story here, and just think about how you do it. And today, I want you to try this afternoon with a conscious decision when you're talking to your patient about, they've been in for dysfunctional DUB, and you're a gyne. Before you dive into the DUB, say, before we get into the DUB, is there anything else? Okay, tell me about what's going on. Ask it in an open way. Make a conscious decision, and then let the patient talk. Believe it or not, she won't be talking for more than a minute, and then you can say that we'll get into the more focused questions. So that's the next part. So the first was important, second was the intro, third was this whole creating the story. Building the story together. Nonverbal, a whole other talk, but how important is nonverbal? What % of communication is nonverbal? So nonverbal communication is probably about 50%. There's the famous Moravian. There's a guy Moravian who actually said it was 70%, but that's in emotional discussions. Most of the time, communication is really more around 50%. In a talk like this, my nonverbal is much less, right? It's because of the mode. But if I'm asking you direction, most of the time it's around somewhere in the 50% range. But there's a lot to do with congruence, and the importance is that if I'm sitting like this, and hope you can see me, and I say, well, I'm really sorry you're having that. What message are you getting? You're getting a non-congruent message. You're getting a message. I'm asking you, that sounds really awful, but I'm sort of saying I don't have time. So making sure that you're congruent with your nonverbal is so important, especially in high emotion situations. So, and there's sending it and receiving it. So I think there's the receiving part, which we talk a lot about, but there's also the sending part. And here's 3 guys, and these are 3 politicians who all got caught doing certain things, and this is the receiving. So this is the micro-expression world. So Tiger on the right has the micro-expression, as does Arnold, and both of these guys were caught cheating on their spouses, and both of them have what we call shame. So they have a down look, they're a down-turned mouth. So you just look at that face and say that's shame. So this is micro-expressions. When you're talking to a patient and they just lost their significant other, there'll be a look of sadness. It'll be quick, but it'll be there. That's the seeing part, the receiving part. this, and the other part is that thing in the middle. That's Anthony Weiner. He got caught doing something else. We don't have to get into the specifics. And he is not shamed. He's actually angry. So you get this little micro expression. You can read it. You got to be looking at the person to get it. And then, there is a time of mask, and we'll get into that in a bit, but it is important. So sending is so important. Making sure you're sitting down, leaning in. All the stuff for the introduction is important. But it makes all the difference in the world. All the good docs that I know that connect well with their patients, if they're talking to them, they're sitting down, they're leaning in, they're tilting their head, they're looking at the patient, and then receiving the message, looking for the micro expressions that they're seeing in sending. So the next part of it is this: active versus reflective listening. So this is the next thing we do. So active listening is something that we all know how to do. So I'm from Philadelphia originally. So, when I'm 18 years old, I'm with the guys. It's hey, how about the Broncos? Is Jorgensen going to start this week? Who's what do you think of the coach? What's going, and just going back and forth. Active listening is something that we all know how to do. Reflective listening is a little different. It's a technique that is just saying back what you heard. So this is different. So, and active listening is fine. So if you're sitting with a patient that and you're saying, what's been going on at work for you, and how's things at home? I know your husband was sick. Is he doing okay? Yeah, sure. Back and forth, checking in. What do you think about, the Iowa football team this year? How are they going to do? That's active listening, going back and forth. That's good. But reflective listening is just saying back what you heard. And it's actually a technique that was invented in 1970. So it's not been around forever. I mean, people probably been doing it. I mean, Sigmund Freud, I'm sure, was doing it back in the 1800s. But reflective listening is a new technique. It was described by a guy by the name of Gordon back in 1970. And it's just saying back what you heard. So, and you can even use a signpost for it. And that's what I tend to do. You can do a signpost like it sounds like is the one I use the most. Tell me about it. But I will do a reflective listening statement with every patient. So at the end of my HPI, so the person has come in, they've got rheumatoid arthritis, they're on the etanercept, it's worn off, and they want to change. So it sounds like you've told me that you have the rheumatoid, you were seeing Dr. Tyler, you switched practices because of the insurance, and the etanercept was working great, but now it's not working. You're having a hard time. The biggest thing is the stiffness in the morning. And you're also having some osteoporosis stuff that you want to take about. Do I have all that right? So that is really my HPI. I mean, honestly, when I put in my HPI, it pretty much is what I said back. And that is a reflective listening statement. And I almost always say it by saying it sounds like, but you can use anything you want. So if I have the story right, let me say it back to you so we make sure that I got it. And what will happen is if you get it wrong, the patient will correct you. They're very impressed that you do this, and they will say, so if you say no, it wasn't 10 years, it was just 6 months. Okay, they'll correct you when you do it, and this really helps you get a good story. And when we were talking back about the importance of this stuff, getting the better story, this is where it really comes in. Good reflective listening, saying back with every patient. And this is where you get the green box on your HCAP scores or whatever survey you're doing. If you say back to every patient, sounds like you're telling me, blah, 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 blah. Do I have that right? The patient will say, my provider listened to me. So the reflective listening is so important. And I like just using the same. It's funny, I have a med student that follows me around and he says, you say it sounds like with every person, you know that? I say, yeah, that's like, you're right, do it. So make sure you do your signpost using it sounds like. So, and do reflective listening. And reflective listening is wonderful. It builds up getting a better story. And it actually starts you on the road to empathy. And empathy is just wonderful, so important. When I get back live, I'll come and do a empathy talk. and get a little interactive on it. But we'll just say today, reflective listening is the key. Now, it's reflective listening with the good body language too, right? So you got to still be leaning in and whatnot, but very important. And this is the data on empathy. And again, if you're doing a reflective listening statements, people in general will say, hey, that's great, empathy. He's an empathic person. And here's all the data, lots of articles, and we don't have to spend time on it. You guys have the handout if you want to look them up. So in summary, what's the block? This is blocking and tackling stuff. What is it? Introduce yourself good. Okay. Tell me about what's going on. Anything else before we dive into that? Let me see if I have that story right. And we're doing empathy. That's an empathy phrase. And empathy is respectful courtesy and an emotional attunement. You're doing it when you're doing that summary statement, that reflective listening. Easy to do. And honestly, again, it really helps me with my HPI. That's the other thing. You essentially, if you hear my reflective listening statement, you're going to get my HPI. Pretty much might be a little more doctor wordy when I do the HPI, but it pretty much be the same thing. Now, there's no place to put this in that that's convenient. But let's just talk about masks for a minute. So some of this stuff, and you're gonna, I'm sure you already said it. It's like, well, yeah, but they all got masks on. So micro expressions, that look of shame that the governor had, is impaired with this. But the eyes are still there, and there's still there's still body language going on. There is a surgery story. I was talking about this with Sue Scambati. She's a colorectal surgery that works at COPIC. And I said, well, you can't tell body language when people have masks on. And she looked at me like I was the man on the moon, which may be true, and said, Dennis, I was working in the OR for 20 years, and she said, you could definitely tell what someone's thinking, even with the mask on. So the eyes do have it. There's still the posture. There's all those other things being sent out. Yes, we are masked up these days, a lot more, and who knows how long that'll last for, maybe for an eternity. I sort of thought it might be going away sooner, but not. But still don't say I can't do body language because they don't have masks. Make sure you're still doing it. So, and just in telehealth, and again, I didn't know where to put this, so I'm putting it here. Bigger is better with this kind of stuff. So when you're doing telehealth, I think of it sort of like stage versus TV. So in TV, or in the movies, you can have a subtle facial expression. Your favorite actor or actress can show their pain or their agony. But if you're up in Broadway and you're watching something, it's the Hello Dolly sort of, there's a lot. Bigger is better on the small screen. Knowing your thing. So for me, on the computer I'm on, my camera is right there, and I think my camera's on right here. But if I'm looking at my patient and I'm trying to make an important point, you really want to make sure you're looking right at the camera when you're doing that. You don't want to be looking off to this side. Make sure you're verbalizing what you feel internally and things like that. So telehealth is important. I actually have long pants on, not the shorts that this guy has, but I love the telehealth picture. So, all right, the final part. So we've talked about those basic things. You always want to use your med list. One thing that I think that's very interesting is this drawing thing. Drawing really increases understanding a lot. So if you're a gen surge and you're doing, you're going to do the gallbladder surgery, get the ultrasound up on the screen, draw it out on a piece of paper, hand it to the person, show them where the gallbladder is, show them where you're going to be cutting. Writing down, if you're going to make some med changes, make sure you write them down. And, unfortunately, a lot of, yes, there is an ABS. I work at a place where there's an ABS and everyone gets it. And it's great. It's about 6 pages. So if I'm with my rheumatoid patients, yes, there's an ABS that they get, but I also give them a sheet of paper and I write down the medicine changes. I just write it down with them and I go over it point to point. The final thing, and it's a new thing in communication, it's only been around for probably a decade, is the teach back method. And So in this case, let's say I'm talking to this guy with rheumatoid arthritis, and he has, we had all that stuff that I talk about, and we're going to switch him from the etanercept to something else. And at the end of the interview, what I will say to him, and I know that he's a married gentleman because I did a social history, and it was a new patient. So what I might say to him is, so tell me what you're going to tell your significant other tonight. Tell me what you're going to tell your spouse tonight, what we talked about. And this is really interesting. I work at a hospital that's under Denver Health. Denver General is a hospital for the underserved. So a lot of the times I'm speaking to someone in a different language than English. And I get some wild. I'll spend 30 minutes with the patient, and at the end of it, I'll say, "Well, tell me what you're going to tell your spouse." And they say, "Well, I have bone cancer." And I say, "No, you have rheumatoid arthritis. You don't have bone cancer." It's an amazing method, and it really does tell you. It helps sort out this whole idea of people understanding. People, if they can't read and write, sometimes really don't understand you, but they're very good at faking it. My mom had severe dyslexia and was really not, she couldn't really write things. So you would never know on talking to her. She was always very interactive, had great nonverbal. So you would never know that she didn't quite understand what this. This is with every patient at the end of every interview. So what are you going to go home and tell your significant other tonight? If someone asks you tonight, what went on today, what are you going to tell them about what we do? Just to make sure that they got all the information. You'll be amazed when you do this. I find that a third of my patients, they don't. I thought I was doing a good job, and maybe not quite as good as I think. So, all right. So let's wrap it up here. Hopefully, I convinced you that communication is important and learnable, and we can do this. And that really the communication parts itself that I want to is introduce yourself. You've got a golden minute. People decide right away if they like you, go for it. Use open questions to sort of build the story. Be careful of your body language. Make sure you're looking at the patient's body language. And then always summarize. Do a good reflective listening thing. Learn what's going on with what they're saying. Say it back to them. And then finally, I think ending with a readback is the bomb. Definitely a new technique, fairly new for me, and a great way to go. So this is where change occurs. If you get back to that 10,000 hour thing of Malcolm Gladwell, you're not going, don't do all these things at once, but find one of them that you want to do. Maybe today say, I'm going to just make sure that I'm going to nail my introduction today, because every patient this afternoon, I'm just going to try it and see if it's a little different than what I did this morning. I'm going to try to do a reflection with every patient today. I'm going to try to do that readback. So, and with that, I think that's it. And I will take questions. I don't know how to stop sharing here, so I'll try, but. So Samara asked about the by the way complaint, and unfortunately that's a difficult. So, if it's chest pain, you're sort of stuck, right? So that's why when you say set the agenda, you want to actually sort of do that early, so in your example, you're doing stroke follow-up. So if you do it early, maybe you have enough time to do it. The other thing is you can do a boundaries discussion. That's the orienting to your process, and what that would mean would be saying we only have you for 15 minutes a day, and I think doing that doing that stroke follow-up is important. Is it okay if we work on the headache at another time? But you bring up the problem with setting the agenda is you want to do it right at the beginning. That doesn't necessarily help you with the time management part, but it's a heck of a lot better than getting to the door, having your hand on the doorknob, and then having the patient say, "Oh, by the way, doc, I got a new headache," and you're so does that help? It's tough. I think it's the hardest thing we do, sending boundaries. Setting boundaries is hard. People wait a long, and I do it all the time. I'm saying, people waited, and the problem is they've waited weeks to get in to see me. I'm talking about their rheumatoid arthritis, and I've got their osteoporosis, and they're on 5 medicines that are, fancy dancy medicines, and they want to talk about their toenails, and I'm like, but at least I can do that in the beginning and say, this would be better if Dr. Smith took a look at this. I'm not sure about the toenail thing. Sometimes that's a fungus problem, and I think that your doc can help you with it. It's better you do the time management at the beginning and at the end. So anything else, you can type stuff in. If that's it, I will, certainly you can email me questions if you have them, or I'll give out my phone number, or, Sally can give it out. I'm happy to talk to folks about any specific kind of things. And take care. It's a tough time these days, but hopefully the Delta variant will subside and life will go on. Things are tough. Make sure you're taking care of yourself. Doing this well actually helps with that. So thanks a lot for your time. I appreciate it.